Hello, Dr. Ola, Dr. Iskandar. Thank you for being here. We're looking right now at a couple of what you called a static surgical guide. As we know, for many years, doctors have been studying and learning about planning for surgery, right? Taking a CBCT plan, planning where the implants go, planning how you're going to do bone reduction, planning how you're going to design the prosthetic and position the prosthetic in the mouth for things to be accurate. And so we're looking here at a bone reduction guide and an implant placement guide. And yes, you've used these in the past, but you see some problems here. You see some things that you don't like with static implant surgical guides. So let's jump in. Let's talk about what we're looking at, what you started using these for, and then why you no longer really like these and you prefer something called dynamic navigation, which we'll get into in a little bit.
Right. So hi, Rob. How are you doing? This is Dr. Ola.
Doing great.
Thank you for the invite. So, as we know with, static surgical guides, when it comes to full arches, really the plan is to use a series of guides that will help you get a predictable outcome, right? So starting from, let's go back to this one for a second, from your anchor pin guide. So this is coming from a dual scan protocol from a denture that the patient has or you made them, right? With some fiduciary markers, you duplicated the denture, and then you put some anchor pin guide holes with your anchor pins for the day of surgery, right? So you're trying to make sure that this denture is staying in the exact same orientation in the patient's mouth as it was before the surgery. So it can guide you to the actual position of the prosthetic, right? So where the teeth should be. So you're still kind of like eyeballing where this is going to go in the patient's mouth during day of surgery. Not to mention that whenever you're actually designing those guides, there's always some inaccuracy, some error factor that's happening in the design process. Then some more errors during the printing process, the finishing, warpage, many other things that could happen. So let's move forward to the next guide. Assuming you had seated your anchor pin guide and all the holes are exactly where they should be, still, you're not sure, if you had exactly positioned this guide where it should be because of the flexure of the material. Dr. Iskandar was mentioning also about the flap reflection. You are supposed to reflect an enormous size of a flap here in order to actually fit this kind of guide. You have to make sure that you're placing those anchor pins deep enough so they don't end up being reduced to the level of the bone reduction. The osteotomy guide, that one comes with more problems as well. The sleeves that you're bonding in here, they could, come out during surgery. There are so many issues, some breakage that could happen. No matter how much you try to stabilize the guide to prevent flexure, here we connected those last two guide tube holes with resin that's actually coming in the way of the palatal flap. Still, that could come in the way of visualizing if the guide is fully seated during surgery. Yes, you are creating some windows, which will actually add to the weakness of the guide in this case. Another issue is during surgery, if, for example, you are unable to get enough primary stability on one of the implants and you have to end up swaying from your surgical plan, positioning one of your implants a little bit more mesial or distal. Unfortunately, this isn't possible to do with a static surgical guide. In this example, we're showing for swappable, not stackable guides. Same issues apply. You cannot change the plan on the spot. And this is why we're going to emphasize on why dynamic navigation offers you so many advantages day of surgery, before that, in order to keep your plan prosthetically driven all along.
This episode is brought to you by Rebel Crown. Are your dental crowns seated in minutes with flush margins and personal one-on-one service? If not, it's your time to rebel. The Rebel Crown is designed by your personal technician who you can call or text anytime. Milled with premium harvest nanozirconia, manufactured here in the USA with a 1-week turnaround time. Learn more at rebel3d.com. That's REBEL 3D.com. Yeah, so a static guide, as you've called it, it's if the guide fits, there's, an assumption, or it's got to fit the mouth, and then everything's got to go according to plan. But if you need to deviate from the plan, then you have to eject out of the plan entirely. Does the guide no longer serve a purpose if you need to move an implant position?
And that's exactly the main issue. So you would have to discard your guide, remove it from the patient's mouth, try to eyeball and freehand where your next implant should be and hope for the best.
Mm,
It's really based on guesswork at that point versus with dynamic navigation, where you can exactly see in real time using your GPS machine where you're going into the bone, the size of your implant, position, angulation, orientation, selection of your multi-unit angle if need be, cuff height, all of that. You can replan it on the spot per se. Versus here, once one implant doesn't go as planned, it's kind of obsolete. You'll have to
mm.
discard the guide and try to freehand your way through the rest of the surgery.
So it's all or nothing.
It's all or nothing.
Dr. Iskandar, what would you say like the top 3, 4 issues with these static guides that you don't like, that you've decided I'm not going to do it this way?
Time consuming.
Okay.
I would say also inaccuracy, right? Inaccuracy in terms of what we just mentioned earlier about the curing, the seating, you name it, right? Sometimes for those who know how to drill inside a socket, in a freehand, when we go to a socket, you might need a little bit to angle your drill slightly to make a point of purchase, then go straight and then start drilling. If you want to go straight ahead on a socket, the drill might slip or something, or you are making too much torque on this drill and it might break with you, right? So having this one sometimes in the socket make problems like that. You can go straight with. Sorry,
You have to go straight.
Angle your drill while going. You have to go straight on exactly, and sometimes the drill's not strong enough and it can slip or break during such a thing. Make sense?
Yeah, and so that with a static guide and you can only go in one angle, you might not get the implant stability that plan is giving you, and you have no ability at that point to try a different method.
Right. Exactly. Try to go a little bit angle right or left or something,
Right.
or something that you can see on the spot. No, you have no choice. What is it? Whatever plan is planned. Right. This can work with some clinicians that do maybe one every 2-3 weeks or so. But for us, doing this almost on a daily basis, right? I don't have the time really to keep doing all this preparation of guide and print and do all this one lot of times. Matter of fact, patients come here, we do the pre-op, we design it, we do it. Dr. Ola finish her design with the patient. We discuss first together what we need to do. And for me, sitting just like 10 minutes or 15 minutes, capturing all this data and making my surgical plan, and I'm done. No cost, nothing. I can be finishing my surgical plan 10 minutes before the surgery, and I'm fine. Versus the other one, no. Matter of fact, I went to the surgery itself, and there is something didn't go well, as Dr. Ola mentioned, and we can just change it. We have one of the cases that I placed implant number 4, and it didn't go well, and it's no way, and it's one of my main anchors. In 2 minutes, I changed location to another pterygoid implant, 26 millimeter, and I anchored the pterygoid while I'm in the surgery. Safe. We can't do this with the statics. You have this kind of flexibility.
It's an all or nothing. Static guides are all or nothing. You either go according to plan.
Static guide is for kind of like the new clinician doesn't have enough experience in the field, and I need something to kind of hold their hands while placing the implant. Okay, and I'm not against that. In the beginning, you need that, right? Same like the Yomi. Yomi is you have this robot holding your hand and you just like push it in place. Okay. Navigation is for those who are good in surgery, understand bone, understand how to deal with it. All what they need at this point is to see the bone while they are drilling. Because you have the sense of feel of the bone, the density of the bone, what you do. You see the bone life while you're working. You determine even the drilling, the drill you choose, either like to drill or to densify, because you see even the bone density while you are drilling.
Wow.
How to stop, when to stop. Because in this one, you are like, okay, you put number 2, you put number 2.5, you put number 2.8, 3.2 implant placed. What if I don't want to go to 3.2 because like, while I'm drilling, I didn't know. I need to be under drilling here. All this kind of things you can't determine if you're doing static.
This episode is brought to you by DES. DES is your one-stop shop for abutment solutions fully compatible with leading OEM implant systems. From tie bases and MUAs to the innovative direct-to-MUA screws and the new DES lock. Every solution is designed to streamline your workflow without compromising quality. Reduce chair time, cut costs, and restore with confidence. Do it with DES. Learn more at des-usa.com. That's DESS-USA.com.
And to piggyback on what Dr. Iskandar is saying, I was actually one of those people he mentioned. So when I was in residency, whenever you fabricate a surgical guide, you have the option of doing like a pilot guide or doing a fully guided guide, So I would go all the way and do a fully guided guide, use all my keys, and to make sure that the implant goes exactly where I want it to be. And if I don't get enough primary stability, that's it. I'll just put a cover screw and call it a day, But, if you are offering this kind of smile in a day kind of treatment for patients, you want to deliver what you promise, right? So with dynamic navigation, you can really see, you can really feel the bone, and you can make your clinical decision based on your best clinical judgment using the handpiece and the system all together while feeling the bone, undersizing, oversizing, doing whatever you want in order to get enough primary stability, like what Dr. Iskandar is mentioning, right? But with a static guide like this one, yes, it offers you like the peace of mind, if you want to say, assuming everything goes as planned, right? It offers you the peace of mind that the implant is going exactly how you wanted, how you planned it, but you don't really care if the patient ends up in a denture or in a fixed bridge the next day. Whereas with dynamic navigation, it really kind of like eliminates guesswork out of the process. If you're able to see and feel the bone, then you will get your primary stability, no matter how sparse the bone is in the patient, it's terminal dentition case, it doesn't matter. You are actually feeling the bone. This is what Dr. Iskandar is harping on. It's very important, as for us as surgeons and surgical prosthodontists, for our plan, first off, to match the execution and to keep it prosthetically driven while getting guaranteed results. So with dynamic navigation, we can guarantee that to our patients.
Well, let's jump into dynamic navigation and,
Yes,
and
so
maybe
let me
show
pull
us
up
some
that
slides
slide.
and show us some of your workflow. And we should make a disclaimer here that XNAV is not paying us, not sponsoring us. They're not paying you guys. They're not paying me. It's just currently, as of today, your tool of choice for dynamic navigation. Is that correct?
So
Even when you're sharing your screen.
if you look at this particular screen here, right? So when you drill, basically you see the bone, right?
Okay.
If you notice this one. In this bone here, I can tell exactly, like I'm in the middle, I'm going through the pass, and I can see how dense this bone is, right? So in this one, actually, I need to have like an over drill, because if I put just like regular drill with this kind of dense bone, I will have bone necrosis. So I see that this one in particular needed much more drill or oversizing to get the implant go there within a decent torque. Imagine with this particular one, this bone density is not like that. It's very mushy. So I will just go with my pilot and maybe 1 or maximum 2 osteodensification drill and go in. Now I can not just feel the bone, I see the bone density. I can determine this piece. You can do this one with the static. Make sense?
Yep. Yeah, you're adjusting your drilling protocol
Correct.
on the fly
On the fly,
based on bone density
as you see.
to get the stability that you need.
Not just that. Imagine here, like if it's very mushy and I need to do bicortical stabilization, right? I can see exactly where I'm going. I can knock the floor, and I see that I'm knocking the floor. And after that, I'm going with the implant and having the tip of the implant anchoring this piece at this point. Like you can do all that. Even you can see visually, like where to stop. I'm going here in a very soft bone, so I'm densifying. And now I came to the floor of the nose when it's very hard. Now I have to drill to knock it up. And then I go with the implant going slowly and I anchor it in the bottom. This kind of visualization and see it live. It's very hard to get this one with the static.
And it's also
That's
very
amazing.
fascinating in cases where you're doing Crestal sinus lifts, right, Dr. Iskandar? So,
Yes.
for example, if you're drilling and you're getting to the sinus floor, you can actually see, just like you did here with the nasal floor, you can see where the sinus floor is, where you need to stop, and that's when you start condensing and actually, packing in your bone grafting material. And then you can start, oversizing, undersizing your drill until you get to the desired size. So many different advantages, whether it's in hard or in soft bone.
I love that. Well, Dr. Ola, could you just walk us through your workflow maybe quickly? Like, so you're taking CBCT and photos and you're importing those into XNAV. And I don't know a lot about XNAV. I assume you are doing some pre-planning. And so you have a plan going into surgery. And then the XNAV is guiding you with feedback in the handpiece into like the position you need to go.
So starting from here, you have your intraoral STL scans from the pre-op appointment, right? You're also capturing a CT scan at the desired vertical dimension. So what do I mean by that? If the patient comes in with a collapsed bite, like this one here, I had him, separate his teeth a little bit. But if you see it in maximum intercuspation, you can see how collapsed his bite is and how we need to increase the vertical dimension a little bit to obtain more prosthetic space, give him a fuller smile, more incisal edge position display. So we captured it at the desired vertical dimension. So I opened up his bite 5-ish millimeters. Use your preferred method, whatever you're comfortable with. So here, for example, I'm using a leaf gauge, stabilizing the posterior teeth with some blue mousse, and taking the CT scan at that desired vertical dimension. Okay, so that's the first CT scan. Next, you're taking another CT scan with the teeth separated. So you can actually separate with any kind of material. Just make sure that it's not going to show in the CT scan. Something like cotton rolls will do. Okay. Or like a bite tab, something like that. So you're taking those two separate jaws from the DICOM and then segmenting them into STLs, right? You're merging the individual intraoral STLs to the segmented skulls, the individual jaws, and taking those and merging them to the bite that you took at the desired vertical dimension. So this is essentially what you want. You don't want to rely on the bite that you're getting from your intraoral scanner, and I'll show you why. There are many examples why we don't like that. They come with so many inaccuracies. I know that intraoral scanners still have a way to go. So I can show you here. This is an exocad showing a huge overlap that's happening between the incisal edges of the anterior teeth. And this is very common, by the way. If you take it in Mesh Mixer, exocad, whichever software you're looking at the bite, there are always inaccuracies. Or for example, you scan the bite, and then when you visualize it, you can see it's only occluding in one point. And it wasn't like this in the mouth, So intraoral scanners do come with a lot of inaccuracies. Not to mention the deflection that happens in the horseshoe shape of the mandible. So here, what I'm doing is that segmented jaw that I was talking about, how I'm merging the intraoral STL scan to it. So when I'm doing the merge, this is showing you like a really accurate merge when you're seeing this kind of rainbow map versus this side that shows all in purple, which tells me that there is some sort of an inaccuracy in the mesh. So my intraoral scan is not completely lining up to the CT scan. So of course you don't want to be.
So it's that cross arch, accuracy
yes.
of data stitching. You might lose some accuracy as you're moving around the arch.
Yeah. So you don't want to rely on your intraoral scanner for the bite purposes. So what I was mentioning here with the workflow, that you're segmenting the DICOM into an STL, taking those separately, merging them to your pre-op bite at the vertical dimension that you want. When the day of surgery comes, you do your surgery, prosthetically driven, of course, with dynamic navigation. You place your radio-opaque caps. So they could be 3D printed, they could be titanium, the material of your choice, really. Okay. And you're doing an intraoral scans for the tissue purposes, but you're also taking a CT scan. Now, you're separating those jaws, okay, with the caps, and you are taking them and merging them to that desired bite. Okay. So that's how you make sure that your bite stays the same and aligns to the desired bite. You're taking those segmented jaws again from the day of surgery and merging them to that bite. You're taking also your records from your photogrammetry system of choice and also merging them to this data, to the data set. Okay, so this is how it looks like with everything merged and with the wax up and how we're able to load it to get something like this at the end. So essentially, this is the workflow. Whenever you're doing this kind of merge, you're looking for the rainbow map. If you see purple means it's an inaccurate merge. Undo and try to select more points. The beauty about those kind of merges that I was mentioning here is that you have so many landmarks that you can use to merge. So if you're still in the pre-op phase, you have the teeth that you're merging, teeth to teeth. But you can also have the anterior nasal spine. You have the mental foramina. You have the genial tubercle. You have the symphysis. So many different anatomical landmarks that you can use. The infraorbital foramen here.
It makes it much easier for the software to merge surface area to surface area versus dot to dot. Like now when you are giving too much data to the software, they have all this luxury for the maxilla to maxilla to merge, mandible to mandible to merge. Versus when you go this fiducial markers, the soft tissue, the software, it doesn't have only these dots to lean on.
This is a really good point around just the volume of mesh data. The larger the surface, the more uniquely irregular the surface is, the better the software will identify it and merge it together.
Right.
And so if you have only a few small points versus, this whole mandible here with unique attributes, it's going to do an excellent job merging and aligning that data, which is critical.
And that's why, accuracy. Like when we do our delivery for the second day occlusion, they are glove fit. Like the bite, you don't really need to do too much adjustment other than slight occlusion here or there. But the bite,
you don't.
Is very accurate.
You don't end up with an open bite or any of that.
You are
bite you have, it's the same bite or delivery.
You're completely relying on your CBCT data for your bite.
Yes.
You are not relying on any iOS surface scan data for your bite.
No.
I love that. Makes sense.
Because look at it. The CT scan read the whole skull, right? In one picture, kind of. Intraoral scan is stitching too many pictures together across the thing. So this kind of stitching in this kind of bloody environment and too many things, I would not say most of the time, but a lot of times you have some discrepancy. It's very hard, especially if you have like back edentulous area, like how you do that. Or if you just left two molars in the back or fiducial things, you are counting on this particular piece to this particular, it's just dots versus surface area.
And this is so good. I mean, you are thinking through the lens of what digital needs to be successful and the behavior of an iOS scanner and how that technology works versus the behavior of a CBT scanner and how that technology works, right? I mean, this is important for a doctor to know about these attributes of the technology that you're using because there are limitations in behaviors of the technology and how it impacts your records.
Correct. And actually, we started this technique almost 3 years ago. Okay.
Okay.
I started this technique 3 years ago on CT scan machine that I already have 2 years before. So it actually, basically, it's 5 years old machine.
Okay.
When the microns was on, the best was 175 microns accuracy of the CT scan machine, right? And it's still working excellent with me. Nowadays, the CT scan machine getting into the market are 25 to 35 microns. So using this, the same technique by nowadays CT scan machine, which is basically now 5 times better than what I have already 5 years ago, and it's working, will make the results even way more superb than I had before.
That's a really interesting point. So you're still using your CBCT scanner from 5 years ago?
Yes.
With 175 micron tolerance.
Yes, 150 microns.
And you're getting excellent results.
Excellent. If you imagine you're using the same thing now with today's CT scan that have 35 microns of accuracy, it's going to be a different scenario.
Well, talk to us about the jaw tracer, jaw tracker, Dr. Ola, that you guys said you're using so the XNAV is, mapping the jaw, and if the patient's moving around, there's a tracking device that you fix in the jaw to make sure everything is stable, right?
Yes. So this is basically, so I'm just going to explain about the basic armamentarium that comes with the machine. So this is the machine itself. Okay. You have the handpiece that comes with the tracker attached to it. Basic armamentarium, you need to have basically your wrenches and tools to make sure everything is nice and tight. Nothing is coming loose during surgery. You have your calibration plate, your calibration armamentarium here to help you make sure that this tracker and the handpiece are all aligned to your cameras. So this kind of work comes in advance to surgery. So you're doing this, or actually your assistants, who are your right and left hands, basically. So they are setting up the system for you. They are setting up the case for success from the start. So they're calibrating the system, they're uploading the plan, and making sure everything is done and ready for day of surgery. So our assistants do that the night before to make sure everything is done and ready to go the next morning. So they're calibrating the tracker. So this is what's helping us, the registration tool. This is what helps us actually X mark or register the points that correlate the camera to the patient's mouth. And Dr. Iskandar can dive into that in a bit once, I finish up with this one. So the handpiece here also has kind of like the same pattern as the registration tool, as the tracker that goes in the patient's mouth. Okay, so all of those correlate together and are seen by the cameras here. Okay, so you're doing your stepwise registration process using those two instruments and correlating them to your tracker that goes in the patient's mouth. Now, how does this go into the patient's mouth, right? So if the patient is dentate, let's assume, right? So that will be stabilized to the patient's mouth using the teeth. So you can use some of the teeth and use like a stabilizing material such as like a bite registration, like blue mousse or whatever material of your choice is. You can use that to fixate it on the teeth and use the rest of the remainder of the dentition to actually X mark a registered system. Now, if the patient is edentulous, then we are using metal pins, which we call them X mark pins. We place them way in advance to surgery day. We have them ready. We take our CT scan with them, and we do our planning based on that CT scan. So this registration tool helps you register whether it's teeth or whether it's X mark pins. And this is the tracker that gets attached to the patient's mouth. XNAV themselves, they have this system that's called EDX. You can actually fixate pins to the patient's symphysis or anterior nasal spine or whichever area of the ramus that you want to attach the tracker to. But the one that we use here is something that Dr. Iskandar has come up with, which are like impression copings or tie bases that you can fixate to the first implant that you had placed and then continue your surgery accordingly. Now, getting to this slide, I know Dr. Iskandar explains this beautifully. So, Dr. Iskandar, if you want to chime in and kind of explain about how you came about, inventing this kind of tracker.
I'll start first by explaining this picture a little bit. Okay. We said navigation. Navigation. So if you talk about the concept of navigation is several components, right? Now, the machine composed of this camera on the top, right?
Mm-hmm.
And we have this handpiece that is the one that you have the drills and drill through. And now you have the patient. Okay. I would consider this camera is my satellite.
Ah, okay.
Right? This is here your satellite. This handpiece now is your car.
Okay.
Or I would say the steering wheel.
The steering wheel. Got it.
The jaw here, or this here, actually is your stored map. Okay? On this stored map that we used previously to build on it, it's map that you have, which is the CT scan, and you put on it the implant, and you put on it the teeth, and you did everything that you wanted to do to draw back the map the way you want it, with the same landmarks.
Okay.
Make sense?
Yep.
Okay.
Yep.
Now, how I will connect that? Now I installed this satellite, the tower. This tower of the satellite. I put it here inside the map. So you have the satellite, you have the car, wheeling steer, and now you install your tower on top of the pre-stored map.
Okay.
Now, this piece, which we call it registration, I need to introduce or to connect.
This episode is brought to you by Rebel Crown. Are your dental crowns seated in minutes with flush margins and personal one-on-one service? If not, it's your time to rebel. The Rebel Crown is designed by your personal technician who you can call or text anytime. Milled with premium Harvest Nanozirconia, manufactured here in the USA with a 1-week turnaround time. Learn more at rebel3d.com. That's REBEL 3D.com.
My map to my driver to work together.
Okay.
That's through what? Through having some dots, pre-existing hard landmarks inside my map. It might be screws, it might be teeth, it might be whatever, to tell the satellite here that these are the landmarks that I have, to translate this positioning to my car. Once this one, the registration tool, connects or introduced the map to your car, now you go and drive. And
Yeah,
the satellite has to be all the time seeing the tower and seeing the handpiece to make the connections all the time related.
The satellite has to have some fixed points in the mouth that are the landmarks by which it knows, even if the patient's moving slightly, it's following those landmarks so that at all times your car stays on the road.
Correct.
or at least the road you want to drive.
Correct.
Yeah.
And how to do that? It's just this registration point, the introducing piece to tell this, the tower, the car, how to connect them to each other, and the satellites now will be in control. They have to be together. That's why every time, if for any reason the satellite moved, it will move the position of the map. So that's why I make sure that this tower is still in place, accurate, and never move. And if it moved, we have to re-register one more time.
Gotcha. So for, the actual surgical procedure, is XNAV saving you time, or is it just giving you flexibility in this dynamic environment that you can, make modifications on the fly? Like, why do you love this method so much for today, for now?
There you go. That's your answer. So many different advantages. Why better prosthetic function? Because you can actually see the overlaid. You're seeing the overlaid pre-op STL to the wax-up STL. So you're seeing exactly, not just in real time where you're going drilling, but also when Dr. Iskandar is saying you can adjust your plan on the fly, you can still correlate it to the prosthetic plan. So you can angulate your multi-unit with the new implant position that you had just planned. You can adjust the position of the implant, the angulation, the orientation, all those things. So definitely it allows you better accuracy. You don't have to worry about the flexure of the guides or anything breaking on you or debonding. Better aesthetics. Why is that? So if you're doing an FP1 case, yes, you can still use something like a bone scalloping guide, like a prosthetic guide, in order to make sure that your bone scalloping is done to the plan, but still ensuring accuracy by placing the implants where you want it to be with the dynamic navigation. Reduce failures. Definitely a lot of time saving with that, because you are getting enough torque from the get-go. You can visualize where the implant is going. You can have enough irrigation in the site. That's the most important thing. With static guides, whether it's like stackable or swappable, it doesn't matter. You're not getting enough irrigation into the osteotomy site. With this, there's nothing in the way. You can irrigate all you want, okay? Faster workflow. Definitely much faster, because once you get the hang of the system, which is a steep learning curve, once you get the hang of it, you can just fly through it. It's really fast, and you don't have to worry about anything shifting, moving. Like Dr. Iskandar said, you do like a system check just to make sure that you're still within the registration points. If anything on the screen shows like it shifted, you have to re-register your points to make sure that you're staying within the CBCT scan and the STL alignment. And this is the gold thing. Can change the surgical plan on the fly, which you cannot do with a static surgical guide. Minimally invasive approach, because you don't have to reflect humongous flaps in order to visualize where you're going. You don't need those flaps for any anchor pin guides. You can keep it very minimal. The other day, Dr. Iskandar was challenging me to do a flapless pterygoid. Did we really have to do that? No, but we wanted to try it, because why not? You can see where you're going with the dynamic navigation system. And so we did that, and it was bullseye, exactly how we planned it, because everything is registered properly. You did your system check. You know you're following the plan. Okay. It's a powerful and stable surgical experience. Exactly what every surgeon wants, because you can feel the bone. You can make your clinical judgment based on the feel of the bone. Am I in a soft D4 kind of bone, or in a very dense D1 bone that I need to make sure that I prep well for my implant to go in with good torque, but without causing necrosis?
So for a surgery day, let's say upper and lower arch, you're placing implants, what's about, I know it's an estimate and it could be plus or minus, about the number of hours you're planning for a surgery day today with your XNAV workflow versus 5-10 years ago? Like how much time are you booking, and how predictable is your surgery today compared to the way it was? What would you say?
Dr. Iskandar will tell you better about this, because he will tell you it's all about the planning behind the scenes.
My planning, my part. Okay. Let me tell you, because there is a certain piece behind the scenes we work together. Okay.
Okay.
Because at the pre-op appointment, Dr. Ola take care of that. She take the pictures, she take the design, she see the high smile, the low smile, the whatever, and so forth. Right? She take all this data to me. before I start my planning, right?
Okay.
Then she comes to me, hey, Mounir, this is FP1. Why, Ola, FP1? Because we don't have enough bone, blah, blah, blah. This is my justification. This is the picture. So plan your surgery FP1. I need the implants to be placed on an FP1 position. So when I do it, I have to make sure that I'm doing it this way. Now I take all this information from her, take her design, do all these things, put it on my XNAV machine, and start plan based on all the teeth and all the alignment she's giving to me to put my implants exactly where it should go with the angulation and select the MUA, blah blah blah, whatever. So now she gave me the final result and asked me now to do my surgical planning to serve her design. Sometimes, you know what? Oh, no, it doesn't work this way. We need to do something differently. So we start to do some negotiation behind I start my surgery to get this end result that the patient like and the patient want before we start my surgical planning.
Okay.
When I get all these givens in my hand, it takes me like 30 to 45 minutes max to finish my surgery planning.
Okay. So less than an hour for your surgical planning.
Her part, I don't know.
So for the design part, so of course, when it comes to record collection, right? I highly advise all clinicians to get the records themselves. It's fine if you delegate scanning the jaws, but you have to be the one who actually determines, is the bite good where it's at? Does it need to be open? Do you need to close the bite from the get-go? Yes, there are actually some cases where you need to close the bite from the pre-op, right? So you have to take it to exocad and do the closure there. But as far as records, pictures are very important. So that's exactly what Dr. Iskandar is mentioning. Duchenne smile, seeing how high the lip line goes. So determining if that's going to be an FP1 versus an FP3 case is the main important thing in the clinical judgment process at the beginning, right? So you have to determine where that lip line goes. You have to see if you have enough bone for you to actually chop off and do an FP3 versus no, I can't. And I have to stick to an FP1 approach in this case. And based on that, you do your proper implant planning, determine where the implant next should be, right? So taking records is essential. Do not delegate this process. And the reason I'm saying that is if you don't get that Duchenne smile at that pre-op appointment, you could be, expecting some disappointment down the line. The other thing is making sure that the patient's head, smile, everything, eyes is aligned. Everything is aligned in the proper dimension. So when you're taking your photos, the patient is looking straight at the camera. Sometimes, when you delegate those kind of important pictures, your technicians or your assistants may not know what you're exactly looking for in those photos. So you are the best judge to look at those photos and determine, do I need this photo to be retaken or such? You don't want, to wait until the patient is dismissed and then you're like shocked with, non-diagnostic kind of pictures for the pre-op, right? So acquiring the CBCT scan at the desired vertical dimension, your photos, your intraoral scans, and the most important thing is setting realistic expectations with the patient. So after pre-op 1, we have what we call a pre-op 2 appointment. So it's an hour-long appointment, and it's with me usually. So I would be sitting down with the patient, and they can bring their significant other or a friend or family member with them. So we discuss the smile design. So I showed the actual digital smile design on exocad to them, overlaid with their pre-op, explain in their case, hey, you are a class 3 patient. We're trying to bring you to an edge to edge. So this is what's going to happen. We're expecting a cantilever here or there. This is what to look for. Are you okay with this? Or if they're like a class 2, right? So if you're trying to push the lower teeth forward, that's going to leave them with a lingual cantilever. Are they okay with that? Do they want to stay in a class 2? All of these things are better discussed with the patient in advance, right?
Oh, yeah.
You don't want to do your implant planning, place the implants and have the teeth exit, the implants exit, from the teeth in a position that the patient and you have not agreed on. So I know a lot of clinicians that just go freehand day of surgery without any discussion of those kind of expectations with the patient. And this is usually what causes issues down the line. So setting realistic expectations, in my opinion, is very important. In addition to that, at the pre-op appointment, what we discuss, a lot of post-op instructions. You will be shocked. A lot of patients will come back like a week or two later and tell you, oh, I've just been eating on nuts and crackers and everything, you know? So discussing the soft food diet, the hygiene protocol, when and how to use the water pick, different kind of things they need to be aware of, timeline of the procedures. Nobody likes surprises. So, the way we like to do it is to deliver sets of temporaries at the beginning, test them more with another set of temporaries after the healing process is done. So we kind of like lay out the process for them, set expectations, and, all of this is done before the surgery.
Yeah, expectation management is critical, right? If you set expectations and you meet those expectations, you did
Exactly.
your job, and the patient's aware of the target.
Mhm.
If those expectations are fuzzy, unclear, or the patient has a different dream in mind that you're not aware of as a clinician, that's when you get into trouble.
Not just that,
I have
we always try to under-promise, over-deliver.
Always.
Exactly.
Like, for example, I see a case, bone doesn't look nice to me, but I know like 80% I can immediate load. But there is a 20% I see, you know what? There is a chance 50-50 that I cannot load it for you. I just ahead of time tell them, I don't want the patient to wake up. Why it's not like I told you, although like I know before. Of course, if I loaded, they are so happy, which is perfect. You give them something that they didn't expect. Now they are even happier and more appreciative.
Yep.
I'll also give you an example of a patient. We got her as kind of like a case that's already in process from another office, another clinician. Expectations weren't discussed before the surgery. She is a severe class 2. Buccal bone was really thin. They did a bunch of chopping, and that compromised her lip support. So they placed the implants too lingual, too palatal, and the teeth were pushed in, and she wasn't informed of that. So just kind of like being on the same page with the patient from the get-go helps you, save a lot of headache, a lot of drama down the line.
For sure. So you have your record taking, and then doctor, you have your surgical planning. So now day of surgery, how long is a typical surgical procedure, assuming things are going relatively according to plan?
For double
How many
arch,
hours
no
are you
more
booking?
than 3.5, at most 4 hours.
For a dual arch?
Yeah.
Half a day? Do you ever schedule two double arches in the same day, or no?
We have done it a lot, but that's too much. Why should I do that? But a lot of times, double and single, for example, it's fine.
Okay.
Or double and few singles right afterwards. Like, double arch and single, full arch. Doing double arch in the same day, I feel it's just too much for me and my staff. Why should I? Take my time, finish by 12-ish, 1-ish, easy. I'm fine. Especially if we are doing this almost every day. So, like, why should I keep...
Sure. One double arch case a day is pretty good practice, for sure.
With few singles afterwards or something, fine. Or single arch.
And not just that, also, we tend to deliver the next day anyway. So we want to make sure that the technicians, the designers have enough time to receive all the scans and start working on them and finishing things for the next day. And, as of, I think, the past year, we had shied away from printing. We're mainly milling, right, Dr. Iskandar?
Yes.
We're not doing printing anymore just because of the many inaccuracies that come with the printing process. And since we're delivering the next day anyways, which, in and of itself offers too many advantages. Like you can check the bite when the patient is seated, they're fully awake, they can actually appreciate the results. You can check the bite, you can scan the bite, you can make them another set of temporaries versus day of surgery when they're just out of it and you can't really check the bite. So to us, that's the most important thing. The patient is able to occlude perfectly. You can appreciate the result that you had planned.
So you're typically delivering their first provisional 24
Next
hours
day.
after surgery. I've actually heard more and more doctors doing that.
Yeah, actually,
Yeah.
we were, I would say we were the first have been doing this one, and everybody was telling us that we are wasting our time and doing things. I didn't care about this opinion. I saw it is the best for me. Patient finish, and I have a very good anesthesiologist with me. Actually, we do like intubated, like angina anesthesia. Finish the surgery within 30 minutes, 45 minutes at most when it's like complicated. The patient is back. It's easy for us to have in a wheelchair to take the CT scan after the surgery. Patient go home and sleep. Why should I keep him in my office with his family? Well, I want to go to the restroom. I want to do this. I want to do that. I need to assign one of my assistant for him. The patient is awake and is fine. Just go home. Let me deal with my lab. Any complication, we need to make some fancy tweaking on the again or something. Like, give me my time. Why should I rush? I have another patient to take care of it. The lab is taking their time, easy. You know what I mean?
No, that makes perfect sense. Send the patient home, let him get rest, come back the next day. And are you, what's your current material of choice for provisionals? Is it milled PMMA? Cool.
As a matter of fact, it's from another part. The patient, when they see their teeth the second day, when they are fully awake, there's their emotional impact different. Now they are awake, they can see their smile. This emotional thing that you can't take it from someone is already out of it, and you forget everything about it. It's different.
And how accurate is the bites with this first provisional? Pretty accurate?
I mean, with this technique, I would say 95, 98% accurate.
Wow. So
and the rest of it, you can just adjust for, scan it, and then you can deliver another set if you want.
So you're getting very, very close occlusion on prototype 1.
Because, again, you're using the CBCT. You're relying on that for your bite. You're not relying on the intraoral scanner.
This kind of merging the files is the key. So this will be like at the if the lab technician wasn't in a good mood and give me some things, the bite will be off. But if they just follow this one, sometimes, a lot of times for me delivering, for example, I don't even open the pouch of the handpiece to adjust. Just it.
Wow.
Actually, it's really like a holistic approach to accuracy in terms of surgical approach and prosthetic approach. So you're making sure everything is accurate. Surgically, prosthetically, everything is adding up.
Actually, we had here, like, we hosted Maxi course here in our office. And happened to be that I'm delivering one of the cases. And with the whole Maxi course student coming there, I'm not making it up. Guys, see the delivery. I screw it, done. They were like, how is that?
So you're actually in some of your courses, you're delivering the first provisional at the course.
Yeah, actually, the day of the course was surgery, like live surgery. But happened to be that I had a surgery the day before. And the delivery was the day of the course. So they had the chance to see the delivery of the surgery that day. And they saw like how accurate it is.
That's unbelievable. Do you have any courses coming up in the new year?
I'm getting lazy. Now I'm counting on Ola. She's the
we do have some lectures. We do have some lectures coming up, hopefully, so stay tuned. But the main one that's coming up is with the UT School of Dentistry in Houston. So we're giving a lecture to the Peri and Pros residence program.
Awesome. Well, if you have any upcoming lectures that you want to give me, I can drop the link in the show notes on YouTube, and someone can click and reach out to you guys.
Sure.
So as we wind down, like, what are you hoping? Like, what's some additional, or what's the next innovation that you're thinking about or hoping for in this world of all-on-X planning, surgery, delivery? What new problems do you want to solve?
I don't know. Matter of fact,
Like
You don't
also
know.
we solved the problem of the prosthesis. Like the prosthesis we are using, actually the material, I'm using shock absorbent material. Like it's the zirconia over BioHPP shock absorbent material. It's almost 40% lighter in weight than the regular zirconia with shock absorbent. It's totally different technology.
The prosthetics you're using you're not using monolithic zirconia. You're using a zirconia bar with
No, not
a
zirconia bar.
superstructure.
We call it BioHPP. It's some sort of reinforced peak, but it's
Okay.
not peak. It's peak with 35% inorganic components that make it much stronger. Very high polishability, like the zirconia. Very light in weight. When you bite hard on it, actually it disseminates all the forces out, so it doesn't have this kind of sounding or impact to the implant right after. We do it straight to MUA. There is no tie bases in it at all. The closest feeling to the natural bone in bite versus the monolithic zircon. Okay, let's get something here.
Yes. So this is the material. So that's what Dr. Iskandar's mentioned. It's called BioHPP. And this is basically the thimble design for the bridge with zirconia crowns or bridges cemented on top. So
Okay.
it's a really great material. Shock absorbing, mimics the natural feel of bone.
So it's a thimble bridge milled with cemented zirconia crowns on top.
Yes.
And it's lightweight, has a little bit of shock absorbing features, not super rigid like zirconia
Right, and it's the same material that had been used for decades in the orthopedic medicine, like hip replacement, knee replacement, joint replacement, because it's very biocompatible and mimics the bone functionality. Here you see. Here is how it looks.
So you see the thimble design? You can also design it as an eye-bar and design the zirconia sleeve on top. But this is the design of choice because it's just easier for, long-term maintenance in case you need to replace one or, few crowns.
I apologize. My AirPods just cut out. I'll make an edit here. Would you repeat what you just said for the last 30 seconds?
Yeah, so basically here it's a thimble design, BioHPP bar, but you can also design it as an eye bar with zirconia sleeve. This design, however, just allows you for ease of maintenance in the future. In case the patient breaks one or two crowns, you can just replace that one segment because you can do it in 3 to 4 segments, zirconia bridges cemented on top of that thimble design.
Full control of the gum color if you want to do it. It can be relying in the future if the patient, for whatever reason, lost some bone. Very high polishability, so it's very hygienic to the gums. Like the gums sometimes can attach to it. This is how same reaction of how the gums reacts to the polished zirconia, right? It's the same way the way it reacts to this material.
Is this a porcelain or a composite material?
Which one?
The pink.
The pink?
The pink one.
Composite.
Yeah.
Yes.
Composite, yeah.
Awesome. And the composite's just light cured onto the thimble bridge,
right.
And then zirconia crowns are cemented.
Right.
It's actually the better grade composite, the ceramic infused, the Creoline. So this is like one of the best composites on the market.
It has slight flexibility, so like even with this one, it doesn't break or crack.
Wow. That's
and
super cool.
I mentioned like this bar and the zirconia and the composite are made in Germany. These people have some kind of technology that kind of like very high. Like Mercedes, like you can't really talk much about that.
This episode is brought to you by the Badger Screw Breakthrough, the ultimate prosthetic screw designed by engineers, breaking through all the screw noise, optimized for direct to multi-unit abutment cases with a sleek 2mm diameter. Mill faster, build stronger, hide those screw channels. American made with best-in-class performance across multiple metrics. The Badger Screw prevents screw loosening and reduces fractures. Great prosthetic outcomes start with great engineering. Visit smartmouthtechnologies.com today. That's smartmouthtechnologies.com.
Then you can see here, you know, how the separate zirconia bridges get cemented on top of that thimble bar with, you know, the composite in between. And like Dr. Iskandar was saying, you can really customize the color of the gum. So that also comes from those really nice pre-op pictures with the retracted photos so that the technicians can see the color of the gums and they can match it perfectly.
And can do a lot of good job on the bridges itself, making some layering, whatever. Like if you would like to go like to the highest level of aesthetics, you can do this one section by section as if you're dealing with the crown bridge style. And also works with singles. If you see here, like in molars, we can use the same technology of the shock absorbent on the very back end ones.
And FP1s too.
I was just going to ask, what's the minimum prosthetic height for this? So you can do FP1s out of this material.
Yes, yeah, there you go.
And so for the bar itself, I think it's 7 millimeters, right, Dr. Iskandar?
Okay. 5.
For the BioHPP? Yeah.
5.
5?
Yeah.
5.
So you'll do for FP1, you'll do a zirconia bridge, cement retained or screw retained over custom abutments out of this BioHPP material?
Correct.
Amazing. How long have you been using the BioHPP?
Since 2016.
Wow. Okay, so you're having great results, and so you got patient recall that you can see, and you're happy with performance, and like, almost 10 years now.
In my office, we see our patient every 6 months. So I have a follow-up of this prosthesis that I delivered 10 years ago till today. So it's not something that I delivered and I don't know anything about it. No, I see the progress across the years.
Making sure they're keeping them clean.
Yeah, and even for me to feel more confidence year by year about this material. Like when I see the performance of the patient, I delivered this for them like 7, 8, 9 years ago, and I see how nice it is till now. Wow.
Yes. That's a good doctor. A good doctor is one who wants to see successful prosthetics in the future. Patient recall is important versus just doing a surgery and saying, have a nice life.
I will not claim I have 0 failure if I didn't see the patient after that.
Yeah.
Of course, I have 0 failure if I didn't see the patient again.
Yeah. Yep. Really good point. Really good point. Well, this has been super fun, dynamic navigation, really exciting. You've been using it for many years, and it sounds like you're really committed to this workflow. You love this workflow, and it's giving you the flexibility you need on the surgery day to be able to, adjust your plan while you're in the mouth to get success.
I would like also to mention something about the navigation. Okay, because some doctors jump into it right away without having the right training, and they get very frustrated and upset and turn this machine to be like coat hanger. Okay?
Yeah.
So
I want to do that.
Dr. Ola joined me. I want to play with this one. Ola, wait. Step by step. Otherwise, you will hate it. Okay? It takes almost a year.
1 year learning curve, you say.
Watch, see. So when you jump in, you will go with muscles already there, right? So when she get that and she was nagging, I wanted to, okay. When the time comes,
I was always nagging. Yes.
I would get, but when she jumped in like pro.
Because she was
there you go.
watching,
It's right
taking
and left.
notes.
Almost how many? Like 50 arch in 3-4 months or something. And she went like fast. But there is some learning curve and certain things you have to learn it well so you can feel that you are doing right. Otherwise, you will lose the interest of the machine.
Mm.
And because I have been there before and I don't want it to fall into the same problems, because I have this kind of frustration moments in the past. And I don't want to face this. Yes, looks nice and fine, and the capabilities are awesome. But if you don't know how to do it, you will get frustrated and leave it and would never go back. Now, look at her in the surgery.
So, Dr. Ola, I assume then the XNAV is indispensable in your surgical procedures.
Absolutely, yeah. Once you go XNAV, there's no way back. Go guided or go home.
Dynamic guided, right?
Dynamic guided, yes.
Awesome. Well, this has been
Dr.
so much
Iskandar
fun.
always says, no bone, no problem, because he can always find the bone with the XNAV.
Yeah? You go sideways?
Mm-hmm.
Always hide the sinus. I will find the bone.
Everywhere.
I'll
always find the bone.
Yeah.
I love it. I love that. Well, thank you guys so much for spending time with me. This has been super fun. Dr. Ola, give me some links to some upcoming courses or lectures or any webinars you're doing, and I'll drop them in the show notes.
For sure. Yeah. Thank you for hosting us.
Of course, this was a lot of fun. Thanks, you guys.
Thank you.
Thank you.